So my name is Karen DeSouza. I'm a clinical research fellow at King's College, and I'm also a consultant medical oncologist at UCLH and Whittington. So thank you for giving me the opportunity to speak about EXODIMER-PET, which really combines two imaging modalities, one being HER2 expression and HER interaction at the level of extracellular vesicles, as well as in combination with whole body HER2 imaging in terms of molecular imaging, and really talking about practice changing imaging and clinical applicability. I'm sort of going to talk about rationale because that leads on to clinical applicability. And looking at my slide, if we move from left to right, the importance of HER2 overexpression in breast cancer really first came into the front line about 35 years ago, where in 1987, HER2 overexpression was known to lead to poorer outcomes and metastases. And this was by signaling through the HER2 receptor itself, as well as crosstalk or dimerization between members of the HER family. This is signaling through MAPK or the AKT pathways. And over the last 35 years, we've validated one means of really looking for HER2 overexpression, and that's immunohistochemistry in combination with in situ hybridization that looks at gene amplification or HER2 copy numbers. And that's what we've consistently used throughout the years to guide our patients towards treatment. And if you move to the center of the screen, you can see a timeline. And from 1998 to present time, you've had several drugs that have been developed to target HER2. The mechanisms of these drugs have been varied, and they've been antibodies and tyrosine kinase inhibitors, antibody drug conjugates, and drugs that inhibit dimerization. And the way clinicians work, and if you look at the right-hand side of that screen, we work on a almost sort of algorithm-like model where we move from one drug to another as patients progress through their treatments. And the important thing to realize with HER2-directed therapies is that all patients develop resistance to treatment. And this is of increased importance, especially in patients with HER2-positive breast cancer that's metastatic. And because they all progress, we keep changing treatments, but our mechanism to identify resistance is limited. So we repeat biopsies to look for persistence of HER2 overexpression, because the key mechanism is loss of HER2 expression or crosstalk between receptors. And so invasive biopsies seem to be the way for us to guide these treatments, in addition to, of course, conventional imaging like CT scans, MRIs, or PET scans. And really, drug development here has outpaced biomarker development, as would be the case in a number of fields. And this has been brought to the forefront more recently, when earlier this year, new generation antibody drug conjugates were found to have benefit in patients with low levels of HER2 expression. So not just patients with HER2 overexpression. And why is that important? That's important because that makes up about 50% of all patients with breast cancer. And when you have about 2 million women being diagnosed with breast cancer every year, that's quite a large number of patients. And so really biomarkers are an unmet clinical need. And so we have, in this project, looked at two methodologies of developing this. So this is working across two NCITA sites at Imperial College, where Dr. Kenny has been looking at whole body HER2 imaging as a means to look at tumor heterogeneity throughout the tumor burden. And if you look at the bottom of the screen on the left, you have two patients, patient A and B, and this is from a different study called the ZEPHYR study, where you have both of them with metastatic disease, and in their matched scans, which are HER2 whole body imaging scans, you can see that patient with patient A does not have HER2 positive disease, whereas patient B in their B2 scan has quite extensive HER2 positive disease, especially in the liver and lymph nodes. And at present, the ability to do this is dependent on a biopsy, which is invasive. It's technically difficult and sometimes not feasible. The second part of this project looks at developing a blood-based assay using extracellular vesicles to look at HER2 expression, as well as look at HER interactions using lifetime microscopy. The ability to do this would allow us to monitor patients while they are on treatment in an iterative and non-invasive manner. And so from a clinical applicability standpoint, we're looking at developing predictive biomarkers beyond conventional immunohistochemistry and FISH to non-invasively delineate tumor heterogeneity with whole body HER2 imaging, and pair that with monitoring HER2 and HER interactions with a blood-based assay, so we can monitor changes in an iterative fashion or manner and really map the evolutionary changes of HER2 and now HER2 low breast cancer. And these will hopefully lead to or contribute to patient selection, treatment sequencing, escalation or de-escalation of treatment, reduce unnecessary toxicities, and contribute to reducing healthcare costs.
McGowan, I'm a research physicist in the University of Oxford, and I'm a consultant clinical scientist in the hospital. So in the Higgins lab, they were looking at different ways of how to target hypoxia. And the mechanism they were using to look at this was to reduce oxygen consumption. So hypoxia in tumors makes them radio-resistant to radiotherapy. You need about 3 times as much radiation to deliver the same level of cell kill in hypoxic areas of tumor as for normoxic areas of tumor. So the Higgins lab did a drug screen of hundreds of different drugs to try and find ones that would cause a decrease in oxygen consumption within tumors. And therefore make them sensitive to radiotherapy. So they looked at a whole variety of different ones, and one of the ones that performed really well and stood out as appropriate for future clinical trial work was this drug called Atovaquone. Now, one of the benefits of this drug was it's widely used already as an anti-malarial drug, and it's kind of FDA approved. It's got a very well-known and low toxicity side effect profile, as well as appropriate pharmacokinetics. So we went on to look at this in clinical studies. So the previous clinical study that we did was called ATOM, and this is a study which was a window of opportunity study, looking at applying Atovaquone prior to patients with non-small cell lung cancer going on to have surgery. So we did baseline imaging, then 1 to 2 weeks after that baseline, we did follow-up imaging prior to them having their surgery. And you can see here in this cohort of patients who had Atovaquone, and the majority of these patients had a reduction in their hypoxic volume following Atovaquone. And in the no Atovaquone group, so the control group, there were actually increases seen in the kind of 1 to 2 weeks between the 2 imaging time points. So how did we measure this hypoxic volume? So this is an imaging conference. I'll talk about the imaging side. So we did this using a tracer called fMISO in PET imaging. So fMISO is a very slow PET tracer. So it acts by passive diffusion, unlike other kind of active transport mechanisms like FDG. So gets injected into vascular space and passively diffuses into cells. And where there's a lack of oxygen, it gets reduced and reduced further, and then gets retained within that intracellular space and trapped, so then you can image it. If there's plentiful oxygen, so in normoxic tissue, it then gets reoxidized and then can passively diffuse out of the cells back into vascular space. And this gives us essentially a way of imaging these hypoxic cells, and we image in Oxford at 4 hours post-injection, so it's a much longer time scale than you do for other tracers, but that allows time for the tracer to enter into these hypoxic environments. The other reason that fMISO is a useful tracer for us to use here is particularly in relation to radiotherapy, this oxygen enhancement ratio I mentioned at the start. The point at which this becomes to be an issue, these sort of levels of hypoxia, is the same sort of point at which the fMISO starts to increase. So we then started very end of 2020, the ARCADIAN clinical trial. And this is where we're applying Atovaquone, this time in chemoradiotherapy patients. So potentially we may be able to see if the lack of hypoxia allows improvements in the radiotherapy side of things for these specific patient groups. So far you can see we're on track to finish end of this year. And so far we've had no dose-limiting toxicities from the patients we've treated. And we've had some SAEs, all of whom have resolved, but none of them have been associated with the drug. They've all been linked to other aspects of the patient's treatment. And unlike other studies. This one uses a time to event continual reassessment model, which allows us to dose escalate a bit quicker than kind of the classical 3+3 phase 1 type trial that might have been done in the past. So from quite early on, we're able to give the maximum dose of Atovaquone that we'd planned, and this is the kind of FDA-approved dose. And obviously, it's the first time it's been used in conjunction with chemoradiotherapy. So as well as having this drug during this imaging kind of window that we're kind of assessing the hypoxic volume change, they have it throughout their chemoradiotherapy. So these are some of our initial results. So we've scanned 16 patients recruited to date. 2 of these, unfortunately, didn't have mpMRI imaging. There's lots of issues with getting the mpMRI tracers supplied and manufactured, so 2 of them unfortunately weren't able to have it. And interestingly, 4 of the patients we have imaging for, so about 30%, didn't show any baseline hypoxia, and that's similar sort of percentage to what we saw in the previous trial in the ATOM study. And you can see here in a kind of illustrative example where we have here baseline imaging. This that's red is the hypoxic part of the tumor, and you see after a couple of weeks of Atovaquone, the red, so the hypoxic part of the tumor has reduced quite significantly. And if you look at it as a whole volume, this is about an 80% reduction we saw in this particular patient. So again, here's some acknowledgements of people that are linked to the trial.
Thank you very much, Professor Ponwani, and thank you very much, Professor Moore. It's a wonderful privilege to go through this presentation, and particularly following on from some giants and some indeed role models in prostate cancer diagnostics and indeed urology in general. So my name's Eoin. I used to work for the NeuroSafe Proof study, which is a randomized control trial run out of NCITA for men with radical prostatectomy. I'm going to take a slightly different tack on this and talk to you about applying multiparametric MRI prostate before radical prostatectomy to get the best for your patient. What does that mean for the 8,000 men who undergo radical prostatectomy each year? Well, it means preservation of erectile function that they had before surgery, urinary continence recovery as quickly as possible, and of course, prostate cancer cure, which is best achieved by avoiding positive surgical margins or cancer cells touching the outside of the specimen. These are mutually competing goals because the cartoon shows you the parasympathetic nerves, which run like in layers of an onion, exquisitely close to the prostate itself, and indeed therefore the prostate cancer. At the end of the tip of this arrow, you can see one such nerve just outside the fibrous capsule of the prostate, and less than or approximately 0.3 millimeters away is this swathe of adenocarcinoma. It can be much closer as well, and you can see that that's difficult to appreciate on histopathology, but seeing it intraoperatively during robot-assisted radical prostatectomy is nigh on impossible with the blood and the motion, and albeit this is a slightly blurry image that I've screenshotted from Professor Shaw. So can mpMRI help in this? Well, it's certainly, as we've already heard in the fantastic talks which have already gone, it has some appealing characteristics. It's available in 98% of hospitals that deal with diagnosing men with prostate cancer. As it's so available in the pathway, it's essentially free, or at least the scanning element of it is. T2 weighted imaging particularly contains detailed anatomic information. However, in previous systematic reviews, there's been considerable diagnostic heterogeneity in terms of the accuracy of radiologists in staging prostate cancer before radical prostatectomy. And indeed, the pooled sensitivity is perhaps a little bit less than you'd like it at 57%. So that really set the scene for some of our work. We looked at men recruited to the NeuroSafe Proof study, all of whom, by virtue of being diagnosed with prostate cancer in the UK, had a pre-existing multiparametric MRI prostate. And we focused our attention on the first 127 men in that study. We looked on a lobe by lobe basis, so 2 sides of each prostate in each man who had an operation, and that's the functional unit of importance because there's nerves on each side. We used a scale of relative likelihood, which is common in prostate cancer MRI imaging, 1 to 5. These have been done before by previous investigators, but what hadn't been done before was looking at the locked sequences of MR in a locked fashion, and also looking at MR image quality to see whether that had an effect on diagnostic accuracy. you can see here is that the proportion of men with extraprostatic extension by lobe per Likert score increases considerably with each step towards 5. And that's very, very helpful information for these surgeons. And indeed, when using the convention to collect 3, 4, and 5 together as a positive finding, sensitivity was much better than the previously reported, and it was at 90.4%. When we looked at the sequences separately, we can see that with every sequence that the radiologists looked at, diagnostic accuracy improved, including giving them sight of the PSA and eventually the biopsy results as well. And the last finding I'd like to present to you shows that the benefit of the higher quality MRI scans. And Francesco Giganti is doing some fantastic work on disseminating the importance of MRI quality, which we can now objectively score. And when we looked at the higher quality MRIs, which represented about 33% of all the MRIs in the study, interestingly, you can see no patient who was attributed a negative extraprostatic extension Likert score of 1 and 2 actually had histological evidence of that. So the conclusions are that you should indeed use multiparametric MRI to get the best for your patient. Accurate staging sets the scene for correct surgery. It's important to understand your own center's practice, by which I mean auditing, so that you can speak to your patients knowledgeably about their likelihood of extraprostatic extension and perhaps their appetite for nerve sparing. Scales that convey relative likelihood are extremely helpful in this respect. Please do use all sequences and then clinical information as well, which might mean returning to the MRI after the biopsy is performed to really dial down and give the excellent detail to your predictions. And you really should optimize scan quality. And these have all been demonstrated, I believe, in our study. Thank you to so many people, including Professor Shaw, Professor Panwani, who was my supervisor on my PhD, and the rest of the NeuroSafeProof team. Thank you.
Hi, everyone. I hope you can hear me and see my slides. So straight into the introduction. So the specificity of mpMRI is reported as low, even though the sensitivity is quite high. And what this leads to is unnecessary biopsies which turn out to be negative or show insignificant cancer. And VERDICT MRI is an advanced diffusion technique which aims to improve prostate cancer characterization and hopefully to reduce unnecessary biopsies. So what is VERDICT MRI? The way it differs from conventional diffusion-weighted imaging is that conventional diffusion-weighted imaging assumes a simple microenvironment for water molecules in tissue, much like the beaker on the left. And this was the behavior of water molecules was described by Einstein, and an ADC value can be computed from assuming normal distribution or Gaussian diffusion. Whereas VERDICT MRI models mathematically the prostate microenvironment based on histology and is a bit more complex. And from it, we can derive metrics which correlate with how many cells there are, the vascularity, and also the stromal space in prostates. So the INNOVATE study is the largest evaluation of VERDICT MRI so far. This included men who were suspected with prostate cancer, who underwent both multiparametric MRI and VERDICT MRI. These scans were then looked at by radiologists who allocated a Likert score, and the positive multiparametric MRIs, which were above Likert 3, were then biopsied, and the lesions that were identified on multiparametric MRI were targeted with targeted biopsy. Clinically significant cancer was defined as anything greater than Gleason 3+4, and subsequently in my PhD, I looked at per lesion working out the ADC value, which is the conventional diffusion-weighted imaging metric, the fractional intracellular volume, which is the metric from VERDICT MRI, which was the most promising from previous studies, and also looking at PSA density. So these are some images from 3 patients from the trial. So patient A, there's an abnormality in the anterior part of the prostate, seen on the left on T2 weighted imaging. This is a FIC map, which shows the lesion, which is quite conspicuous on this FIC map, and also the lesion on ADC maps, which is also abnormal, but not as conspicuous as FIC. And on biopsy, this was clinically significant cancer. Patients B and C have a lesion in the posterior part of the prostate on the right, which was negative on VERDICT MRI, both qualitatively and quantitatively, and indeterminate on ADC. And both these patients had a negative biopsy. So this is the distribution of all those three parameters, subdivided by the Likert score that was given to the lesion. And the main kind of take-home points here are that the fractional intercellular volume and the FIC showed better differentiation of lesions that had clinically significant cancer compared to those that didn't, for both Likert 3 and Likert 4 lesions, which are the majority of the positive lesions, especially important in these Likert 3s, which are indeterminate. ADC was only showed this for Likert 4 lesions, and PSA density didn't show a significant difference between those groups. The ROC curves for these lesions also bears out that the FIC was a good differentiator of lesions that had clinically significant cancer with a higher area under the curve. And when we calculated thresholds based on Uden's statistic, we saw that the FIC threshold had a high sensitivity and high specificity. And when we applied these back to the lesions that were scored as Likert 3 and 4, which was a large proportion of the 165, we found that if the FIC threshold was applied before the biopsy was carried out, potentially 91% of those patients could have avoided a negative biopsy or biopsy that showed insignificant cancer. Conclusions, FIC from VERDICT was an excellent differentiator of lesions with clinically significant cancer. It was significantly different in both Likert 3 and Likert 4 lesions. The threshold has a high sensitivity and high specificity, and it can lead to men avoiding unnecessary biopsy in a large proportion. Ongoing work is looking into biological validation and then also in a different patient population undergoing active surveillance. And we've published this recently in a radiology paper, so please look at it for further details. And we hope to eventually carry out a trial to see whether this will be actually useful in the clinic. Thank you very much, and these are my acknowledgements.